Thanks very much, Annette. Thanks, Anjali. Thanks, Steve, Sassy, Program Committee for the invitation. Always a pleasure to be here. This meeting gets better year by year by year. The program's fantastic this year, and the crowd is great. So well done, everyone. Here are my disclosures. You can tell from that Janssen appears quite a lot. They funded a lot of my trials, so I like dolutegravir, but it happens to be a very good drug. I like bedaquiline, not relevant for this presentation, but it's a very good drug. I kind of like cabotegravir or pivirine, but mainly for the cabotegravir, so that's not Janssen. But anyway, these are my views, and that'll be obvious as I go through, because some of them are a little bit controversial. So I'm going to talk from the perspective of treatment programs, large-scale treatment programs in lower middle-income countries, sort of Asia, but there's not really a particular Asian spin on this, and programs following the WHO's public health approach, characterized by small numbers of regimens for procurement and administration efficiency, and particularly talking about TLD, obviously. And then these public health approach programs are characterized by sparse viral load testing, trying to keep that to the minimum because of costs and efficiency. And then the content is below. I'll start by talking about the current prevalence of dolutegravir resistance, where it's going to, what's determining where it's going to go to, particularly spend a fair bit of talking about genetic barriers to resistance and the viral load monitoring frequency, which I think are critically important. How do we detect dolutegravir resistance? And then at the end, how do we manage it, given the limited knowledge at the moment? So first of all, how common is dolutegravir resistance? So first of all, we have to say how common is viral load rebound on TLD. And this is quite a good recent meta-analysis of 22 cohorts in 13 countries. Only one Asian country actually represented, India. I don't know where the Asian data has gone, but overall, if you look at a more realistic pooled ITT analysis at 12 months, you've got about 10% of people on TLD who are not suppressed. Then if you look at those people and how many of those who are not suppressed have dolutegravir resistance, this was from the WHO's Drug Resistance Report 2024 for a sort of pilot or sentinel studies testing viral load rebound on TLD in Uganda, Mozambique, Malawi, 3 in Africa, 1 in Ukraine. And the proportion of people with dolutegravir resistance ranged from 4%, so below 10% in 3, and 20% in Mozambique, so a pretty wide spread. What about transmitted resistance? Obviously, the consequence of developing resistance on treatment is that they may spread transmitted resistance. Then you've got a problem with people starting therapy at the beginning. So that's pretty healthy at the moment. I won't read out the 13 zeros. But so we're in a good position with transmitted resistance. But can we stay there? So let's predict now, or can we predict where dolutegravir resistance is going to go in the future? One thing I would not have predicted 8 years ago was that I could recycle this slide, which was one of my old favorites. So for unfortunate reasons, I can. Those of you of a sensitive disposition might want to look away now. We can't predict anything at the moment other than things are going to get worse. That's what applies to dolutegravir resistance. We can make educated, informed guesses, and one of the things we can use for that is the WHO quality indicators. So they set 5 quality indicators to say programs are functioning at a level which will prevent emergence of resistance. They're shown here: retention, 12 months after ART initiation, viral load testing coverage, viral load suppression, obviously, ART stockouts, important, so no stockouts. And then this may seem paradoxical, the proportion of people switching to second line. That this might seem to be an indication of bad things, but actually just as long as you've got some on second line, it's telling you that the program's got a mechanism to detect failure and to switch people, so that's what we're looking for. If you look on the right, the red is programs that are not meeting those targets. Green is they're meeting them. So you can see there's as much red as green, if not more so. And blue is there's no data or they're not reporting it, which dominates, right? So this is not a healthy picture for giving us confidence that programs can control the spread of dolutegravir resistance. The other thing, and really the only other thing we've got, is mathematical modeling. And there's a good model from South Africa called the Marisa model. It's been adapted to predict dolutegravir resistance by plugging in dolutegravir resistance parameters to predict estimates of acquired dolutegravir resistance or transmitted drug resistance over the next 10 years. Purple line shows to 2035 the predicted proportion of people who will be non-suppressed on TLD, which is just sitting below 10%. So that's predicted to be stable. Green is the proportion of people who've got undetectable viral load who don't have dolutegravir resistance. Red is a proportion who do have, who are tested. And you can see the red line is rising progressively over time. But I like this slide because the denominator is the number of people being treated. It's not the scary one, which is the one of the number of people who are being tested for resistance, right? So if you look at that, it's about 3% of people in programs who develop dolutegravir resistance by 2035. And transmitted resistance will go up to about 4%. 5% in this model, but that's still well below the 10% threshold where you'd really start to panic about the utility of this, this regimen in your program setting. And the red dotted line shows where we are with efavirenz resistance in South Africa. So, you know, the 10% threshold, efavirenz is sitting there, even though the drugs, that intervention's been essentially withdrawn. So that's the future, potentially, of dolutegravir resistance. It's going to get worse. I guess that's no surprise. It's happened with with most other drugs. So what determines dolutegravir resistance? What's going to drive this up? So viral load suppression, adherence support in programs, everybody knows that. That's critically important. But what I want to focus on is the genetic barrier to resistance, both of individual drugs and the combination regimen and the viral load testing frequency. Because these are critical things that are potentially different in the public health approach. And also just to make the point, and I'm not going to come back to this, but just because you've got a public health approach which limits the number of treatment options, that's the whole point of the thing. You choose a few key regimens. You've got limitations in the options of switches. So whereas in London or New York or wherever, you might have 20 different options you could go to if somebody fails on TLD. In the public health approach, you maybe only have one. And so it kind of amplifies the consequences of developing integrase resistance. So, genetic barrier to resistance. This, to me, is the key consideration for programs in the public health approach. And if you've got a high genetic barrier to resistance of your drugs and your combinations, this protects the regimen during viral load failure. You can't stop viral load failure because people are going to be intermittent with adherence or be various other factors there overall. But this will protect the regimen during virological failure. And this is what assures durability of the regimen long-term in the public health approach. And that also is combined with the virological monitoring frequency, which can titrate the risk up or down depending on how that's done. Now, I'm going to show you some old studies to just make the point about the importance of the genetic barrier to resistance in program settings, just to get across this message. And the first one is the EARNEST trial, which was done in sub-Saharan Africa in a program setting. In this trial, there was no real-time viral load monitoring. We just had the data monitoring committee look at blinded viral load tests, because at that time, about 15 years ago, viral load monitoring was not routine in the public health approach, so it would have been misleading to do the trial with real-time switches. And in the trial, we had a PI monotherapy arm. Now, PIs have the highest genetic barrier to resistance, but we were really stretching these at that time. People thought this was a credible thing to do. After 2 years of PI monotherapy, the DSMB stopped the trial because the viral load rebound rate was much higher in that than the standard of care arms. When we retrospectively went back to look at resistance, what we found was with time on treatment, lopinavir, even though it's a really robust drug with a very high genetic barrier to resistance, if you don't test for viral load and you don't switch people promptly, you build up resistance over time. So up to 80% of people who'd had 18 months or more of uncontrolled viral application had got resistance to PIs, right? So this is what happens if you've got viral load rebound, you've got a less than perfect regimen and you leave that on for time. In contrast, this is a program study. Actually, it wasn't, we didn't call it then, but effectively it is. This was done in the National Health Service in the UK, which these days does resemble programs in many lower middle income countries, sadly. But at that time, they were doing 3 monthly viral load testing. And we put forward the study Pivot. It was switching people to PI monotherapy. And the primary endpoint was loss of future drug options. It's directly applicable to this program question. It wasn't about can we maintain viral load suppression, because we knew the answer was no, there would be more people rebounding. The guidelines committee could never see beyond the rebound question, but really what we're trying to answer is what's the risk of this when you've got a drug, a single drug with a low threshold to with a good genetic barrier, but you challenge it. So 35% cumulative rebound on PI monotherapy, but with 3 monthly viral load testing, there was only one participant out of close to 300 on monotherapy who developed a PI resistance mutation. That was to atazanavir, and actually most of the people in the trial were taking darunavir as their PI monotherapy, and not a single one had a resistance mutation impacting on darunavir. So if you monitor with a regimen that has a good genetic barrier to resistance, but it's not perfect, if you monitor, you can still prevent the onset of resistance. If you don't, as we saw in Earnest, it's a disaster. So we need to choose regimens with high genetic barrier to resistance, and we need to monitor viral load with a certain frequency. Now, the last one I'm going to show you is the Nadia trial, where we had a 3-drug regimen. So now we've got, in this case, I'm going to show you the PI darunavir combined with 2 nucleosides which were recycled, essentially were compromised by resistance in many cases, theoretically, and with program-relevant viral load testing frequency, so every 24 weeks for the first year, and then we had just yearly in the second year, but with an optional one at 18 months. And what we found with the darunavir 2 nucleosides group with that frequency of testing was 90% odd suppressed, 11% rebounded, but not a single person developed resistance to darunavir, right? So you've got in that combination a really robust combination with a drug with a very high genetic barrier to resistance, which is being adequately protected, and you have great outcome in terms of preserving that as a treatment option in the future. When we look at the converse, which was dolutegravir, this was a randomized factorial trial. So we compared dolutegravir directly with darunavir on backgrounds of various nucleosides. You can see that we had less viral load rebound, but you had more resistance, 7 cases versus 0, which is telling us that essentially TLD, or here it was also zidovudine 3-TC dolutegravir, does not present a perfect barrier to resistance. Now let's just look at how things are going to change over the next few years in terms of treatments. And these are the new WHO treatment guidelines. They were announced in Kigali, I guess in July, very exciting. And I was monitoring, because I have vested interest in a number of the studies that were the evidence base for this, and I've been haranguing them for at least 7 years, WHO, to make these changes. So I was very excited by this announcement, and then was monitoring online for when are the guidelines actually going to be released. And I don't know if you can see it there, but the guideline release date there, 24th of December this year. I missed it, actually, so only preparing for this talk, I realized they'd come out finally. Now, who releases guidelines on Christmas Eve? You're either trying to bury bad news, or somebody's responsible. Maybe their Christmas bonus, maybe their job is responsible for getting this out with a 2025 date stamp. So I'm new to ChatGPT, but I thought, let me try and hack into the CCTV cameras in WHO HIV office for Christmas Eve and see what I see. And remarkably, somebody looks very much like Marco Vittoria, putting the finishing touches to these guidelines. Anyway, so here's the new guidelines. You can look them up. They're now online. Actually, they're good. 6 recommendations, right? 4 updates, which really are 2 updates, and then 2 new ones. So to me, and I'm going to explain this, I think this is a case of 2 giant steps forward for dolutegravir resistance in programs, good steps. 1 step potentially back, and 1 I'm a bit neutral about, and let me explain why I think it's going to play out that way. The first one is great. It's taken probably best part of 10 years, certainly 7 years since the Nadia data started coming out, not 17 years as Rainer showed in his slide for this practice to change, but darunavir finally becoming the PI of choice in the public health approach, with the others being relegated to conditional recommendations, a strong recommendation. So that's great from dolutegravir resistance, because it means that robust backstop that I showed you is there in place, and we've got that for if TLD fails. The next one was the beloved switch algorithm of the WHO that had been around for 30 years, has finally been abandoned. So they allow you to recycle tenofovir and 3TC. That came from the second randomization in Nadia. That was the only direct randomized comparison between carry-on with TDF versus switch to zidovudine. And it showed very clearly that sticking with tenofovir, even though there was widespread resistance predicted, was a better option with less viral load rebound. And that was confirmed by a number, not the direct comparisons, but they had confirmatory data in Vicend and DEFT. So it's very clear that sticking with tenofovir, recycling that with 3TC, in second line at least, is a better option than going to zidovudine. The other thing we saw on the data was, and this is, the numbers are too small, but there was a suggestion that zidovudine was also a worse option in terms of protecting against dolutegravir resistance. So 5 versus 2, that was a threshold of testing of 1,000. When we went to testing at 400 copies, we got another 1 in each arm, so it's 3 versus 6. Still not statistically significant, but when you actually look at the pattern of resistance between those who were on dolutegravir, zidovudine 3TC, dolutegravir, tenofovir 3TC, the significance of that resistance profile on zidovudine is much greater. So high, 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 I can read intermediate with zidovudine, and intermediate, intermediate, intermediate for tenofovir, the 3. And those were a 263K, which I'm going to show you in a moment, may not be that significant, right? So once you start to probe into the details of the resistance patterns, you're starting to see that that third drug, whether it's tenofovir, whether it's zidovudine, makes a difference to protecting your regimen. And this brings me to the new recommendation in the WHO, which is dolutegravir and 3TC dual therapy, which from a program setting, I have severe reservations about. The guidelines document is split into two. You have the sort of main document, then you have a supplementary. The supplementary puts the evidence summary for those recommendations. If you look in the supplementary here, you've got, yes, equivalent viral suppression with dolutegravir and 3TC, but where's the resistance? There's no comment about resistance there, mainly because the trials haven't been done that have really been sizable enough or long-term enough and not been done in program settings to monitor for that, as far as I'm aware. So that's a concern. So when we put together TLD versus dolutegravir 3TC, you've got non-inferior viral suppression with dolutegravir 3TC dual therapy on the right. You may have some bone and renal benefits, which, to be honest, are marginal for most people at a population level. But for individual cases, yes. There's no efficacy versus hepatitis B. That's obviously a big problem in program settings and in Asia. I don't know. I've been generous. Possible robust suppression with rifampicin. I think that's questionable. But what I've put here is a likely lower genetic barrier to resistance, which hopefully I persuaded you is an important consideration. And there is some data to support that, which is from Tom Loosley, published in Lancet HIV 2023, where they looked at risk factors. This is people who've got rebound, who are being tested for integrase regimens. It's all mixed up because it's historical data. But I don't know if you can see there, or does this laser pinpoint? No. So you've got dual therapy with lamivudine on that top thing in the thing. So the black dot is 3 drugs as the reference. If you go down, you've got dual therapy. Dual therapy with lamivudine is about 6 to 7 times the risk of having dolutegravir resistance. It's still a low risk, around 3-4%, but it's there. So I think there's a genuine concern about that, especially in the public health approach. So I'm talking here where you may not have frequent viral load monitoring, right? So if you get rebound, you've got an exposed regimen. So I like simple illustrations. Clearly, this is totally naive and stupid, but just maybe as a ram at home, unsubtle take-home message, that's what 2 drugs look like to me. If I were a HIV program manager, fortunately I'm not, but if I were, this is what dolutegravir and 3TC would mean to me. I'd be running as hard and fast as I could away from that to protect my program. But that's just my personal opinion. The data will show whether I'm right or wrong. I was wrong about TLD in programs switching people who'd got nucleoside resistance. Well, there was no data, but WHO was right. PEPFAR was right about that. But I do really have concerns about this when we've got something that seems to be so good with TLD, and why expose that to more risk. The last one is something also close to my heart, a new recommendation, which I was surprised to see in the guidelines, and but happy, was cabotegravir rilpivirine long-acting therapy 2 monthly. And it's close to my heart because I was involved in running the CARES trial with CISI, which was designed for a program setting. So all of the trials, cab rilpivirine treatment up to then, were were targeted at pharma licensing. So you had viral load testing up the wazoo every month, every couple of months, right? Totally irrelevant for program settings. Again, the risk of getting a misleading answer about how safe this would be in a program setting. So what we did was strip out all of that excess viral load testing and just test viral load at the WHO recommended frequency of 24 weeks. And we looked after up to 2 years, so we could see whether it was durable. Some people, when they present this, say, oh, it's wonderful, we got 80% of people with injections on time. I'd say from a trial utility perspective, it's great this had some applicability to program settings, because 20% of people did not have their injections on time. And despite that, we still got excellent viral load responses. Suppression at 96 weeks was non-inferior to standard TLD, which was a comparison here, right? So viral load suppression looks wonderful, as do all of these studies, but you have to look at the risk of resistance, right, if I'm getting this across. So in the cabotegravir rilpivirine arm, we had 4 people with confirmed virological failure over a denominator of a couple of hundred plus, and 0 on TLD. And it wasn't because they were all taking every pill every day. It was normal non-adherence, patchy here, patchy there, as you'd expect in a program setting. So again, it's starting to suggest that you might have a lower genetic barrier to resistance with this regimen. Those 4 participants who unfortunately developed rebound, 1, the sequencing failed, but the 3 where it succeeded, we found cabotegravir resistance in all 3. If you look at the bottom row, you can see, I'm going to come to it in a moment, a 155, a 118, and a 148. Those are all archetypal dolutegravir resistance mutations too. So we had low, and high dolutegravir resistance. The WHO guidelines, to their credit, in the supplementary do put, and they did look at resistance on cab rilpivirine, right? And in cab rilpivirine, you've got 12 out of 20 who developed dolutegravir or INSTI resistance, and you've got 0 out of 30 on the comparator arm, not always TLD, but usually an integrase-rich arm. So again, it's saying the same message. If you go to 2 drugs, you might be exposing the program. So the individual, if you monitor viral load, can be managed, especially in resource-rich settings, but you're exposing the program to an accelerated risk of dolutegravir resistance. So again, but this time if I put cabotegravir rilpivirine up against TLD and just look at the pros and cons, the same sort of things come out as DTG plus 3TC, also with a lower genetic barrier to resistance and questionable durability in the public health approach. But the thing with cabotegravir rilpivirine, which I think does it for me, as opposed to dolutegravir 3TC, is that clearly many people who require long-term treatment for HIV absolutely love being freed up from pills and having 2 monthly injections. So there's a very strong preference for people living with HIV amongst some. And for those who are really struggling with adherence, this may be an answer. And you can see there are potential major programmatic advantages of this. So this one is clearly a trade-off. There are very clear advantages to selectively using this intervention. Now, let me just quickly go. That's all the factual basis. I'm now just going to go through clinical management rebound. This should be relatively straightforward. You've got somebody on TLD. They have a detectable viral load above whatever threshold is your favorite. You do some adherence counseling, and you repeat that. And if that viral load goes below your threshold, you just carry on with TLD, straightforward. If that repeat is above your threshold, then you can do two things. You can immediately switch to your backstop, which is robust, and you have good confidence in its success, which is tenofovir 3-TC darunavir, or you can do an INSTI resistance test to inform that. And if there are no dolutegravir resistance mutations, you might carry on with more adherence counseling. If there are resistant mutations, then you would then switch to darunavir. And by doing that, you're sparing a switch to darunavir. You're avoiding the increased costs associated with that and potentially increased pill burden, or that may not be the case. At the moment, as I showed you, the risk of dolutegravir resistance, intermediate high-level resistance, in people who've got detectable viral load is quite small. So you'd be doing 100 INSTI resistance tests, perhaps to pick up one person who you definitely know needed to switch, and a few more who you'd be left in some limbo about. So you really want to de-risk or de-cost that resistance testing without delaying things too much. And this is where I think this is very interesting. You can go with a sort of past history, like being on DTG 3TC, or you could use a tenofovir urine test, right? To say, okay, this person's been adherent, they've still got rebound, let's test them. Of course, if you're on DTG 3TC, the tenofovir urine test isn't going to be much use to you either, just by the by. So that's a management algorithm for detecting dolutegravir resistance. What if you find it? This really, we're in the foggy ground of really not knowing what to do, so sorry to disappoint you there. I will give you a few comments, though. There are 4 key resistance mutations to dolutegravir: 263, 118, 148, 155, and then you get secondary mutations which can compound the impact on susceptibility, but not all these mutations are equal. If you've got a 118R, that's really the end of the story for dolutegravir. It's 18-20-fold increase, but any of the others, it's a couple of fold with one mutation. If you detect that promptly with your reasonable frequency viral load testing and intervene, you may be able to salvage that. So 2-fold with a 263K. There's anecdotes of suppression with a 263K, and now I can show you, because we just published it, the resistance that came out in CAB rilpivirine. So I showed you there's dolutegravir resistance 155, and then there's a 148. Both of those people resuppressed switching to TLD standard dose, right? So just proving in a way that we could follow up. We haven't got the durability, but we show that it's not the end of the story if you've got a dolutegravir resistance mutation. So this is really whether to switch or not to switch. We're unfortunately in the realm of expert opinion, and whoever you talk to will have a different idea. I would say we've got a robust backstop. And just to go back to that mathematical model I showed you early on, the thing you can do to prevent this increase is actually switch people promptly to darunavir, or do that, manage that transition of testing and switching better. So I think at the present time, you might want to, if you've got resources, to switch. So here's a summary of the points, that are quite a number of points I've made, but let me just quickly put them in. So at the present time, dolutegravir resistance is not really a concern for starting TLD. TLD is highly effective. About 10% have got unsuppressed viral load after 12 months. The genetic barrier of DTG is high, but it definitely is lower than a PI as a single drug, and it's not impenetrable. We can overcome it. There's a low to medium risk of acquiring dolutegravir resistance during viral load rebound. That will probably go up. 2 drug regimens, this is probably the controversial one, may increase dolutegravir resistance, but there's insufficient evidence of how that would play out in programs, but it's amplified by infrequent viral load testing. If you've got dolutegravir resistance, the consequences are not always clear, but some are. Darunavir 2 nucleosides is great. Thank you, WHO, for getting around to that. A program should stock it. You've now got a robust backstop, and you should switch promptly, such as resources allow. And at present, then, to go back to my title, which I'm hardly spoken to directly, but at present, dolutegravir resistance has little impact on care in Asia, but future predictions suggest that it will, and hopefully what I've gone through will prepare you to prevent that. Thank you very much.